Oh, good afternoon, everybody. Thank you so much for joining us. We are honored to have Dr. Kee Park, who is a lecturer on global health and social medicine at Harvard Medical School, give us a seminar this afternoon. He received his medical degree from Rutgers University and trained in neurosurgery at Temple University Hospital. He has previously been named the Paul Farmer Global Surgery Scholar at the Program in Global Surgery and Social Change, and served as the director of spine surgery and Myung Sung Christian Medical Center in Addis Ababa, Ethiopia. He is the director of the North Korean program at the Korean American Medical Association and currently serves as a consultant for the WHO and on the WHO Expert Advisory Panel on Surgical Care and Anesthesia, advocating for and assisting in the development of national surgical plans by member states.
Are you done?
Yes.
Let me share my screen here. Let me see here. Can you all see the slide?
I can see the slides.
Great, great. Well, Nicole, am I saying your name right? Nicole?
Yes, you are.
Okay. Yeah, I mean, Nicole, thank you for inviting me to give a speech, the lecture here. I'm really honored to speaking at the Ohio State University, right? The group of residents. It's an honor and privilege. So, we went back and forth on what to talk about, and ultimately we decided on this topic: global surgery operating beyond the OR. So I'm a surgeon. I'm trained. As you heard, I did my residency in Philadelphia, and we're surgeons are trained to be excellent technicians. So if you look at our specialty, surgery, neurosurgery, the ones that I think we've are legends, right? The ones that have sort of left their mark in the profession of neurosurgery are the ones that are, that revolutionize the technique, right? Cushing versus, and the microsurgery, Yazagil, they're able to now do amazing things with their hands. It's sort of like the Top Gun pilots, the fighter pilots of it's the most technically advanced. That kind of skill is what's been sort of celebrated within neurosurgery. I'm sure it's the same in other surgical subspecialties. What I'm here to tell you today is really about the public health aspects of neurosurgery. Is there such a thing? I would argue that there is. And I think, and hopefully by the end of my talk, you'll understand why it's so important and why it's important for neurosurgeons, or surgeons in general, that this should be part of their overall training and also their practice. So I finished my residency in 1995, and I went to private practice in a small town south of St. Louis in Missouri. Loved it. This was my dream. I never wanted to do academia. I just wanted to be a community-based neurosurgeon, head of incredibly busy practice, loved the community, started my family there with my wife. And I was there for about 12 years, and something happened. I think I reached a point where the American dream that I had dreamt, I got it. I was there, living a very comfortable lifestyle, having everything I could possibly want and having all of it. But I wasn't happy. Something was missing. And, one day my wife and I, we're talking, and we said, to those much has been given, much is expected. And somehow that's actually a verse from the Bible. It really rang home for us. And we said, well, maybe there's a reason that we've been given so much. And then the expectation really for me is to serve others, especially the ones that are less, privileged and in poor parts of the world. And that started my journey into global health, global surgery. So what did I do? I started volunteering. There's an organization called Foundation for International Education in Neurological Surgery, FIENS. They've been around since the 50s. It's a U.S. organization, sends certified surgeons for credentialed to places around the world where they're lacking neurosurgeons. And the idea is to train the trainers. You teach them how to operate at training centers. And I did this in 2007, and I worked in Ethiopia and Nepal, and I loved it. I just said, this is exactly what I wanted to do. So I came back to the U.S., shut down my private practice, and started working initially in Ethiopia on a regular basis, became the director of spine surgery. So I'm a spine surgeon. I do brain surgery as well, but mainly I do spine and reconstruction spine and spine trauma. I started working in Ethiopia. So here's some pictures. So the obligatory pictures with those, so the sink for the scrub sink, that kind of stuff. I'm not sure I want to start using, I might take that picture out now because it's really not that relevant anymore. I think what's more relevant and as I study global health, is how I approached my intent to help, right? Well, so I had this idea that here I am, a US trained neurosurgeon. I'm going to bring modern neurosurgical technique to Ethiopia. How arrogant is that? But that's exactly how I thought. I had really no global health training at all, to be quite honest. I was a surgeon, and that's it. I never understood how, this colonialism, the power dynamics, the cultural sensitivities, the ethics of working in a high-income surgeon from high-income country working in low-income country. None of that I had really studied or was exposed to. I just had a good intention, and you know what they say, right? Good intention there's road to what? I forget the saying, but you know what I'm talking about. Here's a woman who had a spine fracture, brought these incredibly complex sets, spine sets from the US, and then did the operation. Of course, she does great. I take my pictures and say, look, now you can do modern spine techniques in Ethiopia. And we actually published this. But here's the problem. As soon as the implants were depleted, the surgery stopped. And on top of that, we were bringing implant from company A, then the next 3 months later, company B. We're using all kinds of systems. And I can imagine now, if these patients come back for revisions, what do? How do you, we weren't really thinking ahead about, these things. Or what happens when the implants run out? What's the, we needed to figure out sustainable solutions. And that was never in my mind. And then here's something that really shook me deep down to my core. So I was working in Addis Ababa. This mother brought her 11-year-old daughter to the clinic because she had heard that a US neurosurgeon was working in this hospital. And she took 2 days with this girl and took a bus to get to the clinic. And she had fallen from a cart a year ago and broken her back. There were no specialists to see her, obviously. And then gradually she lost function of her legs and bowel and bladder function. We took a CAT scan, x-rays, and of course she's got a complete transection. It was an unstable fracture that eventually transected it. And we were explaining to her mom, that there's nothing we can do surgically. It's too late. And as the resident was speaking to the mother, I snapped this picture of this girl. I had no idea what they were talking about. Then the resident turns to me and says, Dr. Park, the mom says she has 2 other children at home, and there's no way she can take care of this daughter and the 2 children at home at the same time. Can we help her find a place to leave her here? And I was just like, I have 3 daughters now, but I had 2 daughters at the time. And this was her expression of the girl as the conversation was happening. Can you imagine the pain that you experience, the guilt? And then I started to think about, and what happened was we were able to collect some money and then tell the mom, please go back home and here's some money to help you for the time being. We did not want to see her leave her daughter in Addis Ababa. But then I started to think is about what's the problem here. Of course, there weren't surgeons over there, but the real issue here was poverty, right? It was the fact that these people were living very poor conditions. And then, the whole idea of even saying that these people are poor it implies that they could be wealthy if they wanted to be, right? But the truth was they were hardworking, and there were forces beyond their control which kept them from being rich. And I would, at that moment, I come to realize that it's not because people aren't poor because it's lack of money. There's plenty of money in the world. The problem is the rich are not willing to share their wealth with the poor. It's the misdistribution of wealth. And that, to me, it's the greed. That's the root cause of so much of our pain and suffering. It's the root cause of really most of our global health issues. It's and I put the responsibility back on the rich, not on the poor. I'll just have one slide because on North Korea, because I'm Korean and I have a heart for the North Korean people. I've been there over 20 times, and I used to, my last trip was there in November 2019. I took this picture of in the OR, and this scalpel, if you look carefully, it's rusty. And it's because North Koreans are socialized for scarcity. They have more scalpel in the cabinets. I've seen them. They won't open it until this one is completely dull. And you start wondering why they think like that. North Korean people are also hardworking, industrious people. But the problem is they're in a state of war with South Korea and US. And it's the failure to reach a peace process that is causing the diversion of millions of dollars. In fact, 30% of North Korea's budget is used on their military to defend themselves against the threat of US attack. Imagine what they could do if they were able to achieve peace, send the soldiers home and reduce their spending on military so they can spend it on health of their people. There's more than, the health is not determined by skills as surgeons or radiation oncologists or internists. By the time people seek medical care, it's too late, all right? And we are able to fix some of them, but not all of them, let's be honest. What determines health of the population is beyond the technical aspects of healthcare. It's really about poverty. It's about geopolitical factors, socioeconomic factors, things that are what we call social determinants of health. So much more important than the ability to operate and do surgery well. So in 2013, my family and my 3 daughters moved to Cambodia. So when I started working in Ethiopia, there were 3 neurosurgeons for 90 million people, all in Addis Ababa. Right now, they have 45 residents in training. That Ethiopia model has been wildly successful, and they were training their own selves. My former residents are now trainers in Ethiopia. And in Cambodia, they had just started a residency program in 2013 or so, and I moved my wife and my daughters over to Cambodia to work in a government hospital. And I loved it over there. I still miss Cambodia. This is a picture of me doing surgery, a craniotomy, and the drill they use is basically a handyman drill, Home Depot drill. And I put this picture on the right over there for a reason, because this is a cover that's designed to fit over a Home Depot drill, but it could be re-sterilized. And there's a special swivel at the front that allows you to grab it so you can stabilize it right by the skin. This drill cover costs a couple of $100. You don't need $10,000 drills from Medtronic or other these companies. You can use drills straight out of the hardware stores if you're clever and use something like this. Innovations can really save a lot of money. So I'm going to talk a little bit about what it's like to work in the public health aspect of neurosurgery. And this was my first foray into it. So one of the things that we did at the government hospital is to actually collect data on all of our patients that were admitted to the neurosurgery department. Number one cause for admission, head injury, period. Okay, 75% of our admissions were traumas, and then half of that, or 3/4 of that was for head injuries. And the head injuries, the mechanism was almost always from a motorcycle accident. So if you look at Vietnam, Cambodia, Thailand, they're all using little scooters, they call them motos. And because it's hot and for other reasons, they don't wear helmets. So what we saw was that 90% of our patients who were being admitted for head injuries, they weren't wearing helmets. And the injuries that they were having were not what we saw in US, which was a high velocity, a rapid deceleration injury from car accidents, right? They get subdurals. They had, avulsion of, bridging veins. Subdurals have a much worse prognosis because there's parenchymal damage as well. In Cambodia, more than half of our patients were having epidurals, which was becoming very rare in the US. And so epidurals, as you well know, it's a small laceration of the meningeal arteries, and you get a blood clot external to the dura. Brain is fine. If you take that out, the patient literally wakes up and walks out of the OR if you let him, okay? And this was the majority of operations, an easy operation. So one of the things that we looked at was, can we look at the helmet usage and see what kind of outcomes you get? For instance, there's a 7-fold increase in odds of presenting with a much worse neurological condition if you didn't wear a helmet versus if you wore a helmet. There's almost a 4-fold increase in the need for surgery if you didn't wear a helmet. And then we actually collected what we call, Glasgow outcome scale at the time of discharge, because it's hard to get follow-up. But we also show that at the time of discharge, there was almost a 3-fold increase in having worse neurological outcome if you didn't wear a helmet. This study was really, for me, very important, because this is one of the few studies where head trauma patients were evaluated using data from an LMIC. If you look at the head trauma literature and if the neurosurgical literature, 80% of the studies that are done are in high-income countries. And then they recommend things, and then those are not generalizable in lower and middle-income countries for multiple reasons. One of them is the epidemiology for one, but the other one is the level of care they can receive. But this one was actually data that we collected, primary data, in the same environment that were relevant in the lower and middle-income countries. So here's what we did. We started writing op-eds in Cambodia. And then that was in December 2014. So our op-ed was, head injury data makes clear the need for new traffic law. Then about a little over a year later, the Cambodian Ministry of Interior, they passed a new law for helmet law. And I'm not saying that our work was, A cause B, but I'm sure it was one of the key factors in driving them to go ahead and increase the helmet usage. So that's, and here's what I, as a neurosurgeon, that did not take a drill or a scalpel or a bovie. This was actually data collection, research, and advocacy, basically a pen. And I bet you we saved maybe more lives using this than the operations that we did to save the lives of the ones that actually had the head injuries. So neurosurgeons could really make a difference if you through a public health approach. And it was during this time in Cambodia when I read the Lancet Commission on Global Surgery report that was published in 2015. Maybe some of you read it. When I read it, it just blew me away, because at that time in Cambodia, I was starting to kind of get this vague notion that the problem is more than just more neurosurgeons that could be solved by training more neurosurgeons. It was really a health system problem, a surgical system problem, workforce, infrastructure, all those things. And so when this report came out, and it showed by the numbers the significance of the surgical availability in the developing countries, especially the poor, right? 5 billion people don't have access to surgical care when they need it. About 143 million operations currently are not being done that should be done. And of course, the implication is that these patients are either dying or being disabled. The estimates are about 17 million people die a year because of lack of access to surgical services in the developing countries. And then this report also talked about the economic losses, and they estimated 21 trillion losses in loss of GDP if the world failed to act by investing in surgical care. Powerful stuff. I read this and I basically called up the people that wrote this up and says, "Can I work with you? And I want to apply these things to neurosurgery." So I came back to US in 2015. And I became a fellow in the program in global surgery and social change, where now I'm a faculty. And I went ahead and enrolled, and I got a master's in public health. So if you want to change things at the population level beyond the OR, you really have to speak the language of the policymakers and the public health professionals. And that's where the master's in public health is really useful. And then once I finished this, I was asked to stay on as faculty because there just aren't that many people who are surgeons who had on-the-ground experience, public health training, and a fellowship with the Lancet Commission people. So I stayed. So now I'm going to talk a little bit about global surgery, right? So within the global health landscape, surgical care was a neglected stepchild. In fact, that's the word that Paul Farmer and Jim Kim used in 2008. Surgical care is a neglected stepchild of global health. Well, in 2015, as I mentioned, the Lancet Commission came out and it just blew everybody out of the water, right? With showing, you know what, this problem is the number of people that are dying is more than 3 times more than HIV, AIDS, TB, and malaria combined. So with that publication, and there was also another publication called Disease Control Priorities, the 3rd edition, and the entire first volume was devoted to essential surgery. And this is also another public health publication. And with those 2 publications, the world took notice. And then there's a annual meeting of all the health ministers in the world in Geneva. WHO hosted. It's called the World Health Assembly in May. And they passed resolutions to sort of prioritize their activities for the year. They passed a resolution in 2015 calling for strengthening of emergency and essential surgical care and anesthesia as a component of universal health coverage. A Zambian mission sponsored it. It was sponsored by a gentleman named Emmanuel Makasa. He was the health attaché in Zambia at the time. He's an orthopedic surgeon from Zambia. He will always be remembered for this resolution. That is, and everything that has happened in global surgery starts with 2015 onward. This is what set everything in motion. So with that resolution, the World Health Organization started to include 6 surgical indicators among their 100 list of WHO core health indicators: perioperative mortality rates, surgical volume, surgeon anesthesia, obstetrician density, and also affordability of surgical procedures. And it's really important to get these indicators into the global governance. The reason is what we don't measure, people don't respect. If you measure it, people will start following it. So this is now part of the indicators. So how do we get a country to strengthen emergency and essential surgical care nationwide? It's not like building a hospital, right? It's looking at the entire surgical system and trying to build it out and looking at the and how do you build out a health system? So what are the building blocks of a health system? It's quite simple. WHO has already worked that out. There's information management, service delivery, human resources, medicines and technologies, and financing. And you also need to have good leadership and governance. There's still 6 building blocks of a health system. And what the Ministry of Health needs to do is take these 6 domains and then look at surgical care and look at the baseline, where they are, the current gap analysis, and where they want to go, and then develop a national surgical plan. And this is where Harvard Program in Global Surgery is working in this particular policy development space. And so we work with WHO and develop this manual for strengthening surgical systems using a health systems approach. And as I mentioned, we do analyzing baseline indicators. We get a broad consensus with all the key stakeholders in the country in surgical care. We figure out where they want to go. We cost it and budget it, and we help them implement it. As you can imagine, these are not cheap plans. These are, in Zambia, it was $400 million. Tanzania was about $700 or $800 million. The Nigerian plan is over $1 billion. So this is a picture from the WHO Regional Committee from 2019. And so within the Western Pacific region, this is in Manila, there are a couple of surgeons who are ministers of health. And it's not bad. That's not a bad thing to have surgeons who are ministers of health when we try to do global surgery. And they really push for a regional framework for action for this particular region. And so the WHO Western Pacific region, 34, 36 countries in this region, they're at the forefront of everything because there's all the other regions, Afro, EMRO, and APAHO and things like that. But Western Pacific region has been the bright light and really pushing the global surgery movement forward. So this is a most recent map that I have. shows all the countries that are working on national surgical plans either have completed it or are in the beginning stages of it. And I would tell you, this is we are now past the tipping point, right? The number of lower and middle income countries that are working on this is more than half. So the global surgery movement is here, it's happening, and the momentum is building every year. This was we used to do these workshops. This was actually held in Dubai with ministries of health, invited members of ministries of health and ministries of finance, and then we go through the steps in developing national surgical plans. And then because of the COVID, we switched to a virtual webinar format, and we just finished a three-part webinar series for the Western Pacific member states. We had the regional director from the Western Pacific region, also regional director from the Southeast Asia region, Dr. Kasai and Dr. Poonam Singh were also there. And then we had a whole webinar, a 2-hour webinar, all on financing, because without money, all these plans just sit on the shelves. And we had Jim Kim, who was the former the president of the World Bank, and Mohammed Pateh, who's currently the head of health, population, nutrition at World Bank. And they are all here because they're interested in helping financing national surgical plans at some level. And we also had a government representation from KOICA, JICA, the Korean and Japanese aid, USAID, and also DFED, MFED, the New Zealand and then Australian funding agency. We also had Islamic Development Bank there. So here's something that's really exciting. This was so on the U.S. side, we also have a team working with the appropriations for global health. So everything works by the Senate and the House. They come together and then allow they figure out how much to be spent on all these things. We were successful, and this was, I have to give credit. There was an organization called Mobile Surgery International. Liz Moore and Michael Nebeker, good friends of mine, they led this effort. Harvard was part of that effort, and we're able to get language within the appropriation bill that specifically called for USAID to spend money on surgical care. And heretofore, it never existed. So this is in there now for this year, the fiscal year 2021. If you look here, it says, USAID administrators shall support efforts to strengthen surgical health capacity on these conditions. They also talk about surgical system strengthening, and they also talk about national surgical obstetrics, trauma and anesthesia plans. Now the USAID gets this, mandate, and they have to now start spending money on it. And this year, what we're trying to do is actually tie a dollar figure to the language, and we're working on that right now. So one of the things that Nicole asked me to do is, what are the opportunities for fellows, like residents? What could they do? So the Programming Global Surgery and Social Change, our website is on the bottom, pgssc.org. We have a program that where residents like yourselves spend 1 or 2 years with us. And typically they're from surgery, neurosurgery, obstetrics, and anesthesia, but it doesn't have to be. It could be other specialties as well. And it doesn't even have to be clinical. Okay, we will welcome epidemiologists and public health people as well. But these research fellows are typically surgical residents, and they come and spend 1 or 2 years, primarily, helping out with the Western Pacific work, some of the research, policy development, implementation science, those kinds of things. So now I'm going to move a little bit to the global neurosurgery, because the reason I came to the PGSSC was because I wanted to apply the same playbook to the neurosurgical profession. So same thing. We started with May of 2015 as myself, and then I read it. Walter Johnson is a gentleman in the middle, and Bob Dempsey is the chair of neurosurgery at Wisconsin. And the three of us were in a meeting in Rome and we were together, and we said, "Did you read the report?" He's like, "Yeah." "Did you read it?" "Yeah." "What are we going to do about it?" Well, as luck would have it, and maybe it's not so luck, maybe it's divine, providence. But gentleman in the middle with the glasses, Walter Johnson, is a neurosurgeon and an MPH, an MBA. And he was selected by the WHO and hired to implement the resolution 6815, the global surgery resolution. So he was there not just as to do neurosurgery, but to help roll out the implementation plan for the resolution. And he asked me to help out with that because he didn't have a staff to help. And that's why I became a consultant at WHO. But because Walt is a neurosurgeon. He said, Key, let's figure out a way to develop global neurosurgery within the global surgery movement. So we went ahead, had some strategy meetings, and then we convened a meeting in Geneva in 2015. And one of the things we wanted to do was start off with a big public declaration saying, hey, we have a problem here. We have a lot of people who aren't able to get access to neurosurgical care. What are we going to do about it? And whose job is it to fix it? So it was called Bogota Declaration. I think you can look it up, Bogota Declaration and Global Neurosurgery in December 2016. The WHO was there, the president of the World Federation of Neurosurgical Society was there. The Minister of Health from Colombia was there. This was in Bogota. And the declaration basically said there's a globally huge unmet neurosurgical needs, and it is the responsibility of neurosurgeons to fix that problem in a collective fashion. And so we put sort of a, we put a flag down on the ground saying we have to fix this. And so one of the things that we did at the program in global surgery is to apply the same playbook, and then let's looked at what is the unmet neurosurgical need globally. How do we know that? So we went ahead and did some a massive research project looking at all the neurosurgical conditions, and then we published this in Neurosurgery, Journal of Neurosurgery, and we came up with a number. There's actually 5 million unmet neurosurgical operations currently in the world. And most of it is in these countries that are red and yellow, right? Sub-Saharan Africa and Southeast Asia and South Asia. And in order to meet that demand, we will need additional 23,000 neurosurgeons today. And we also knew that we have about 49,000 neurosurgeons that are currently in the world. So we need to increase that by 50%. So how are we going to do that? So we said, here's the fire, let's put it out. And one of the things that happens when you say there's a fire and then you say you need to put it out, they'll ask you, how should we put that out? So anyway, this information was now embraced by the World Federation of Neurosurgical Societies, and it's on their website. If you go to the WFNS.org, you can see the neurosurgical densities within these countries. And we've actually now had a one iteration done, so we can actually track 2 data points separate, things like 3 years apart, and we're going to do another one. The idea is to track. Remember, you can't manage what you don't measure, and we're going to measure the neurosurgical workforce trends in as many as we can in these lower and middle income countries. So people come to us and say, well, how should we fix that? Well, we don't have a good answer for that. No one's ever really looked at how do you scale up neurosurgical services, and what's the evidence behind that? So we actually did a massive literature search on current evidence that's available. And then we first attacked head trauma. Why is that? When we did the 5 million estimation study, we saw that more than half of it was TBI. TBI is the condition that global neurosurgery should attack first and foremost. And we saw this in Cambodia, but we confirmed it and validated it in our research. So we came up with a report. It was called Comprehensive Policy Recommendations for Head and Spine Injury Care in LMICs. And it addresses not the clinical care, not clinical care recommendations, when to put an ICP monitor in, when to take the patient to the OR. No, this has to do with recommendations for the ministries of health to manage these conditions countrywide. It tells you, so we came up with an estimation of you need at least one neurosurgeon for a population of 200,000 people to at least meet the neurotrauma needs of a given population. So 1 per 200,000 people. This is the kind of stuff that the ministries of health actually need to plan and figure out how many neurosurgeons they have to train. We also showed, using our Cambodian data, that after 4 hours, the neurological outcome deteriorates significantly. But until 4 hours, the Glasgow outcome scale it stays about the same. This is 4 hours from the time of injury and the time they arrive at the facility. So we thought, we can at least say you might be able to place neurosurgical centers, but there should be the population should be no more than 4 hours from a neurosurgical center. That has massive implications, because if we apply U.S. standards of trauma center within 1 hour, the golden hour is 1 hour, right? That's a lot more centers than if you say 4 hours. So those are the kinds of recommendations that went into this particular document. And it's been adopted by the ministries of health It's first in Pakistan and other. Now it looks like Fiji is going to adopt it shortly. And then the other thing that's happened is that the World Federation of Neurosurgical Societies has decided that global neurosurgery is something that they need to embrace. And in order to do that, they formed a committee, an ad hoc committee, and they asked me and one of the gentlemen from Morocco to be co-chairs. And we came up with a global neurosurgery action plan. And so I'll share that with you. This action plan has 5 objectives, okay? And these are all starts with letter A, okay, the 5 A's. The first is to amplify access, right? We need to make sure that we increase the number of surgeons, the facilities, those kind of things. Amplify access to timely, safe, and affordable neurosurgical care. But that's not the only thing we're trying to do. The other thing is we want to align all neurosurgical activity towards achieving universal access. We also know that there's been a paucity of research coming out from LMICs, especially on the service delivery, workforce, infrastructure, those kinds of public health aspects of neurosurgery. And we said we need to advance relevant research, especially from authors coming from the developing world. And we also knew that we didn't want to have a health system where there are just neurosurgical centers around the country. We need to work with other parts of the health system, trauma surgeons, pediatricians. We have to have them all. So we wanted to assimilate our activity to the overall surgical system strengthening efforts. And lastly, we want to advocate for neurosurgical care in all health care benefit packages, right? We want to make sure that the governments put neurosurgical services as part of their overall benefit package. And then we have specific targets within these objectives that are measurable, that are relevant, that are time bound. For instance, one is Perform 2020 Global Neurosurgical Workforce Survey. And we're actually almost wrapping that up. So there are multiple targets. And our hope is to actually have all these targets hit by end of this year and then reported at the World Congress of Neurosurgery, which happens to be in Bogota, by the way, 5 years after the Bogota Declaration. I'm going to talk a little bit about research in global neurosurgery. As I mentioned, myself, Dr. Walter Johnson, and Bob Dempsey, we were in Italy, and we've all read the Lancet Commission report. And so one of the things that we did was we wrote an article. It was called Global Neurosurgery, the Unmet Need. And then that's the first time we really, cemented the use of the word global neurosurgery. And then so if you look at the PubMed search results looking for global neurosurgery, at the beginning of 2016 is when this article came out, there has been an explosion of research. And this is in 2018, 2019, 2020 continues to explode exponentially. And this is, we've given research in global neurosurgery an umbrella, a searchable term that we could all use. And there's been research into neurosurgical care in LMICs and delivery prior to all this, and I acknowledge that. We're not saying that it didn't exist, but we now have a name for it. So global neurosurgery is now the umbrella where we all do our research. This is Jim Kim giving a talk at the AANS in 2019, the Cushing Oration, and he used that slide. I gave it to him because he said, listen, global neurosurgery is an exciting thing that's happening. It's one of the things that neurosurgeons can be proud of. And I'm going to finish off with this particular slide, which introduces a new journal that's coming out. It's called Journal of Global Neurosurgery. And our inaugural issue will be next month. And I'm the editor-in-chief, inaugural editor-in-chief. And the reason this journal came about was because we started to see that we're trying to advance relevant research from LMICs. But then they ran into problems like they can't afford to pay for article publication fees, processing fees, which can range from, a few $100s to a few $1,000s. These journals want to be paid to publish your articles. And then, or if you wanted to have your article open access, you have to pay additional fees for open access fees. Or if you didn't pay that, then these articles are hidden behind the paywall. You all know this in academia. You have to pay $40 a pop to read these journals. And we just saw this as a completely undermines what we're trying to do in global health, which is democratize all this information and make it as easy as possible for researchers and LMICs to be able to publish and build research capacity. So we actually started this journal as a nonprofit. And there will be zero fees to be publishing, and it's all open access. No one has to pay anything to read it, and then hopefully we'll get PubMed indexed and things like that. And then there's one thing more we're doing about this, which is we will provide assistance to researchers from LMICs without any expectation of authorship. We just want to provide assistance so that they will have a fair chance of getting their articles published. You know, we're all native speakers in English. That's not the case in, researchers in Zambia. You know, so we've been taught how to do research techniques and data analysis and statistical analysis. These are the things that we take for granted, which are not given, to these researchers. So we said, let's teach them. So there are organizations that will actually do what we call accompaniment and then support these researchers so that they can become competent enough to submit to journals like this, and also to much more competitive journals. And then, of course, from a content standpoint, we will focus on the public health aspect of neurosurgical care. Not so much how to do surgeries better, but how do we deliver neurosurgical care to all who need it? That's what we will deal with this journal. And hopefully you'll be able to see it when it comes out next month. It'll be all online. There's no print issues. And I'm really proud of this project. So that's the end of my talk. And hopefully I've inspired you to look at neurosurgical profession, or even surgical profession, beyond the OR, and then think about it from a much bigger perspective. Thank you very much.
Thank you so much, Dr. Park. This was fantastic. Now I will open up the forum for questions. If you have a question, feel free to unmute or raise your hand and I can unmute you. Otherwise, I will start. So my first question for you is, you mentioned the really successful Ethiopia model. Would you be able to tell us a little bit more about it, what it entailed? Yeah,
so as I mentioned, Ethiopia, by the way, do you guys have cameras, or is that something you just cannot use? Or I'd love to see your faces. Oh, there you are. That's great. There are people behind these. Yeah, so the Ethiopia had 3 neurosurgeons in 2007, and they were all in Addis Ababa. So if you're living in, outside of Addis Ababa, Aksum or Gundar, you have an epidural hematoma. That's it. There's no one there to take care of you. So it was a joint effort, but it was led by the Norwegians. I have to give them the credit. Norwegians actually partnered with, it was University of Bergen with Addis Ababa University, and they started a residency program at Black Lion Hospital and the Korean hospital, the Myeongsang Christian Medical Center. So they started the residency together, and then the US group, the Foundation for International Education of Neurological Surgeons, started sending volunteers to help teach, with supporting team, the teachers. And it was successful in the sense that the residents, and not all residents that we trained stayed in Ethiopia, I'll be honest with you. A number of them actually ended up in the US or other places. And this is called brain drain. You may have heard about that. And that's something that has to be, they could make so much more money. Let's face it, we're working in other countries, even within Africa. You go to Botswana, you'll make multiple what you make in Addis Ababa. So, but a number of them did stay and then became faculty. And then now the residency program is theirs, right? So they have their own, they run it, they train them, and now they're getting into research. We just had a really fantastic meeting with the faculty at the Addis Ababa University. And because their training is so, it's now maturing, and each resident has to do a research project, a thesis, before they graduate. And so now they want to, say, hi, can we talk about research collaboration? And I say, yeah, absolutely. And I know exactly what you can submit it to also. So,
that's fantastic. How much does it cost to train a neurosurgeon on average? I'm curious.
Where? In Ethiopia? I have no idea. I think in the US, it's got to be a lot of money, guys. Yeah.
Yeah, I'm sure it's a lot in the US. And that's actually one of the points that I sometimes see like these efforts to, especially, linking this to the brain drain issue, where people have these, as you mentioned, very well-intended ideas of training someone from a developing country in the developed one, but then how do they, transfer the skills to a place where they don't have access to these toys and these tools and these imaging modalities that they get used to in the training. And that was one of the sort of commentaries I heard from some of those people who were privileged to train, for example, in the US. And then they were like, well, now I'm I'm scared going back because we don't have any of this that I'm used to using in my clinical practice. So I was curious, what is your take on, how to do this right, I guess?
Yeah, I don't know the value, practical value of bringing a neurosurgeon from, let's say, Ethiopia to Columbus, no, Columbia. What, you guys Columbus, Ohio, or Columbia?
Columbus.
Columbus, sorry. Bring it to you guys, OSU, and give them a fellowship, right? A training for 6 months, and then have them go back. What's he gonna do with that? You know what I mean? There are a couple of issues. Number one, I don't know about OSU, but other places, foreigners cannot scrub in the US, right? They're just not allowed. It's all observerships. Listen, that's crap. That's crap. I mean, really, we go there and we put our students and put them in scrubs and then let them operate wherever they want in Ethiopia or wherever, right? But then an attending from Ethiopia comes over to US and says, no, you can't touch the patient. It's this whole colonial mentality. And there's this within the program in global surgery and social change, one of the things that we've because of what happened last year with the George Floyd, we've actually taken on a very strong stance on anti-racism, and then it ties into anti-colonialism, because global health really is really tied into the colonial roots, and so my master's house, we're not allowed to enter, and that's sort of the phrase that people say, and it's the message, so if you're going to bring them here, let them scrub in, treat them with dignity and the same respect that we get when we travel to those countries. So that's one. I just had to digress a little bit about that colonial roots of global health. But the other thing is, it's so much better to understand what the needs are locally. So if they're doing, they're starting to do, let's say, brain tumor surgery, and then they want to start to do, let's say, a little bit more challenging skull-based operations. Okay, you identify a technique that you want to upskill, then you figure out together what's the best way to do that. If that's the case, you might want to send someone from the, someone who can do the operation better over to that country and do it in the same environment that they'll be doing it in. I think that's the ideal situation. And I will tell you, US doesn't have a monopoly on the best surgeons in the world. Okay, we might think that back here, the U.S. exceptionalism, but we don't. There are surgeons from South Africa, the South to South collaboration. It's more practical because someone can fly up to Addis Ababa from Cape Town. It's cheaper, it's quicker, it's easier, rather than someone from, let's say, California and go over there. So this whole I don't know if I answered your question, but yeah, I agree with you. It should be training in the context of where they're going to be practicing. That's the best way.
Yeah, absolutely agree with you there. You also mentioned the high prevalence of TBI. I remember a project from the 70s and 80s in New York City, actually, which was called Kids Can't Fly, because the TBIs were predominantly in children who were falling from heights from New York City buildings. So they had to put like nets around the buildings to decrease this. And I was curious, did you see the prevalence of these also among children and younger people, or was it kind of all over age-wise?
No, well, we do see children falling, and we actually took care of a number of them, because the building codes in those countries are not as strict, right? So, kids do fall. And then there's a huge building boom, at least in Phnom Penh, where I was. High rises are going up left and right, and the how high should be the railings, and how wide should be the railings. All those things weren't as tightly regulated. So we did see, unfortunately, a number of falls. And I'll tell you an interesting story. We actually looked at spine fractures, and then we followed it for a year. And then we looked at the number of cases and the mechanism. And there was a bimodal peak. There was in the spring, the number of spine fractures went up, and we went down during the rainy season, and then it went up again. And then we're like, what's going on here? And then the Cambodians immediately picked up on it. They said, oh, it's from our palm sugar industry. So these are palm trees, and palm syrup is very coveted. It's one of the sources of palm sugar. But to get that, you actually have to climb up this tree and you have to snip the flower. And then from the stamen, I think you get drips of the syrup, and then you have to go in and collect it the next day. And so you could imagine someone is climbing this tree that's, 30, 40 feet high, going up there and then replacing it, and putting the receptacle in there, and then bringing down the full receptacle. And they do that. The season is in the spring and in the fall. So one of the things that they do is, it's sugar, so they ferment it and it becomes palm wine. So they would have a few drinks. They go up and down, they fall over. And I worked in Missouri. You know what? Beginning of the deer season, and maybe you see it in Ohio. You see a few guys falling off the deer stands. You can predict it, and it's spine fractures. So I thought that was pretty interesting.
Yeah, and I guess it ties the sort of neurosurgical issue very tightly with labor safety or workplace safety in a way. So these things, I guess, are very intertwined, as you mentioned, that it's really a systems issue more often than necessarily an individual surgeon being accessible or not, for that matter.
So I have a follow-up on that story. So in Thailand, they actually designed they crossbred the palm tree in such a way that it's only like 6 feet high. So
that's a good idea.
I thought they should get a Nobel Prize for that. I mean, it's so
that's brilliant.
Yeah. So they just walk up to it and switch out, and
Can't get hurt. Yeah, that's great, actually.
And then also the coconuts. Coconuts was the other one. They would climb up and get it. And then so one of the solutions to that is they would train monkeys to climb up, and then and then throw down the coconuts. So there's some ways to reduce work injuries in those those industries.
Very interesting. Does anybody else have a question? I feel like I'm talking a lot.
Well, I'm just
Go ahead.
Oh, I'm here because my husband is a general surgeon. I'm on the faculty in the physical therapy division.
Great.
And of course, you're talking about like neurosurgery not being available, like rehab for people after they have these, catastrophic injuries is just really worldwide is just not where it should be. So I guess I'm just interested, like, how did you start out to like develop all of this? Because for somebody who wants to do like global, wants to get more global type initiatives going to improve, either general surgery, rehabilitation, where would you say people should start?
That's a great question. And so, first thing the way I got started was I volunteered, right? I went overseas, and then so where can I use? There are clearly places where I think someone like you could go. All services, rehabilitation services are far behind, I would say, than what it should be in developing countries. I will tell you that the policy recommendations for head and spine injury in lower middle income countries, the report that we wrote, there's a whole section on rehab.
Okay.
Because we had surveillance, pre-hospital care, prevention, surgical care, and rehabilitation was we made sure that we talked about that. So WHO actually has a department for rehabilitation, and it's actually headed up by a Korean woman who I know. So that's another way to sort of get involved and saying what's happening from a WHO standpoint, where are they working, what are their guidelines. So
that's an idea.
Yeah.
And see what kinds of initiatives maybe we have going on.
Yeah. And so I got frustrated after I was volunteering and saying, oh my gosh, the surgeons that I'm training, they come out, but the health system won't allow them to have a CAT scanner, a whole OR team, because it requires a commitment from the government. So now, because of the resolution that I talked about, and because neurosurgeons are at the table for stakeholder engagement, they're saying, you know what, in our country, we only have neurosurgery here, but we need them here within the next 5 to 7 years, right? They give input to the ministries of health. They incorporate that into their national surgical plan they talk to the World Bank, Islamic Development Bank, or COICA, whoever, and says, all right, can we get this program implemented? That's what I wanted to see happen in Cambodia. But every time I talk to the Ministry of Health, they're like, oh, we have other competing priorities, you know? So not anymore. Surgery is now, we're right up there. Yeah, no.
It's phenomenal what you've accomplished. Really amazing.
Oh, I'm part of it, but I'm really grateful that I played a part in it. Yeah.
Do we have any other questions at all? If not, I will thank you again for a fantastic talk, and thank you so much for answering all our questions. We wish you a good evening to Park City. Happy healing. We won't tell your
Thank you.
surgeon that
Yeah.
you're skiing. And have a good night. Thanks so much again.
Sure, Nicole. Thanks for asking. Bye, everyone.
Bye-bye.
Okay.